Good. I was just asking the tech person how are we starting. So he said there's nothing, no prelude. I only have to start. So I was just
I will do that honor, and
okay. That's what I was asking him.
Briefly introduce all of you all, and then jump into another program which is happening parallelly right now. Get into that, and then keep hopping between the two.
Yeah.
Saturday has been a busy day for all of us, especially the back.
There's so many things happening. So many things happening.
Yeah. So we had quite a number of registrations today, about 150. I can see about 28 are online, and we still have 5 minutes to go before.
Yeah, I think people join by another, they don't really join at 3:30. By 3:40, you have more people.
More people coming in, yeah.
So by the time the formalities are done, I think there should be more people.
Yes. You're based out of Delhi, right?
I'm based in Delhi.
Okay.
Yeah. I'm heading the Gynae Association of Delhi.
Okay. Yeah. You had a good program the other day.
Yeah, we want to have another one because there is a request to do it on a Wednesday.
Okay.
So I'm
just share the date and time with us so that we can quickly check on the availability of Zoom and allot it to you before somebody else takes the slot.
Yeah. I'll do that in a day or two.
Yeah.
Actually, first I have to ensure, there are enough people on that day. Like it's just not taking the date and then asking people. I do it the other way around. First ask the people and then take a date.
Yeah, makes sense. Yeah. Otherwise, it's a lot of effort which goes into doing all of this, and then, if we don't have the required audience.
But we got a lot of appreciation for the program last
time. Oh, did you? Okay, very good. Really nice to know that. Yeah.
Yeah. People really appreciated, and they said even their friends want to do it, but not on a Saturday because Saturday somehow is a very busy day for everybody.
Okay. OPDs must be heavy on Saturdays.
No. This webinars, so many webinars on Saturday.
Good afternoon, sir. Good afternoon.
Hi, good afternoon, Suman. How are you?
I'm good, sir. How are you?
Good to see you. All well. Yeah, good to see you all.
Good afternoon, Dr. Achila. Nice to see you.
Good afternoon, Dr. Suman. How are you?
I'm good. Somehow.
Yeah.
How is the school's program shaping?
Oh, school program is going on very well. Very, very well. In the last 2 months, we have done about 82 workshops, sessions.
Yeah. We are starting in April because our schools, opening in April. So I asked for a first program on first week of April.
Yeah. Even we'll start in April, sir. Our schools are also opening in April.
Okay.
So that it will be better, better way to communicate.
Just let us know the date and time, Suman.
I've already taken.
Okay, you've taken already. Okay.
I've taken for 2nd of April.
Okay. Yeah.
I've not taken the date, sir. I will go and take from the principal.
Yeah. Okay, that's fine. 2nd of April. Yes. 1 to 3 is your program as well.
Yeah, 1 to 3. Yeah, 3 schools.
Yeah, 3 schools.
Yeah.
At one go, sir, we can take 3 schools, no? Or
any number.
Take as a number.
Okay.
So long as it does not exceed Zoom.
Yeah.
We'll be on Zoom, so no problem. What are the timings, Dr. Achala, you have kept? Timings?
Kept from 1 to 3.
1 to 3.
It depends.
That's what the school asked for, We have to see their convenience, not ours for that.
Children at that time, they start moving for the house, for their homes. Because in our place, the school ends at 2 o'clock or something like that.
Yeah, it's regional differences,
Yes. So we'll ask the principal, they will suggest us what.
Yeah, exactly.
That's what they do. That's what we do that. We ask them, whatever time they say, we give it.
A certain date. Once a principal suggests a date and time, then you can mobilize other schools for the same date and time.
Yes, sir.
If they agree. If they don't, fine. That's fine as well. So I can see almost 52 in a matter of 3 minutes. Yeah.
Good number.
Yeah.
Good number.
No, Technology has connected us. Otherwise, we would have never seen each other.
Yes. Never seen, just heard the name now. Should have only heard the name. Yeah, this person. But now we can know by face, we can recognize. I think this AICOG, when we are going to meet all of us, then we can know by name, That will be the biggest advantage. Otherwise, somebody say, oh, that is Dr. Achla Batra is going. Now I can myself know that Dr. Achla Batra is there.
Yeah, definitely. Looking forward to AICOG.
One big boon of this COVID pandemic. And we're learning so much now. Earlier, we're not used to learn that much, because whenever you go in a conference for a physical meet, we are only out of the hall talking to each other. Sometimes only some special talks we used to focus upon, not all. So,
we have decided to change our, we have a monthly meeting every month in Delhi from our societies. We have decided, COVID or no COVID, has become virtual.
Virtual.
Traveling time is saved,
Yes. At home you can and keep watching your home. What going on, and then you can sit there. And I think after 2 or 3 months we can meet a physical meet.
Yeah, we can have something like a workshop where hands-on is required.
Yes. Because this physical touch is also very important.
Yeah.
Because when for the last 2 years we're longing to meet each other.
Yeah. Now physical meets have started in Delhi.
Yes. Even in our place we have started.
Yeah.
But our senior doctors, they don't come. Still, they don't come.
People are not very keen on going for physical meets now.
But gradually they will come.
The basic idea they were telling me was that on Women's Day, don't have any academic program. Okay. Let's meet, but we'll celebrate Women's Day. Academics are okay for webinars.
Very good. 8th March. And we are planning for just a pre-Holi meet, So Holi is on 19th, so we're planning on 17th. Just a small meet for 1 hour.
I think we have about 70 of them now. We'll wait for another minute or two, and then we can start off so that we don't waste anybody else's time anymore.
Sir. Yes.
Sriman, you're there? Or is it Bashir?
Yes, sir.
Okay. Is that Bashir?
Yes, sir. I am Bashir's colleague, sir.
Okay. Just check with him. Sriman must have started the other program. Just check with him.
Yeah, I'll check and I'll let you know.
Yeah, check with him. Yeah, and also check with him whether he had sent the links to. I'm sure he has done it. That's how Achala is here, and the others are here as well.
Okay.
If he has
we'll
sent
check, sir.
Basab and Parikshit.
Okay, sir. Just give us 1 minute.
Yeah, no worries. Shall we start then? In that case, we have about 80 people now. Good afternoon, everyone, on a Saturday evening. Thank you very much, each one of you, for joining us on this important session, which is related to respectful abortion care. And this is a flagship program of our beloved Foxy President, Dr. Shanta Kumari. And it has been done in collaboration with WHO, and who are the principals in terms of funding this entire operation for us, which is being scaled up across the country in all the societies. RAC itself, is a terminology which has come about in 2021, which has gained a lot of importance and forward thinking. And it has taken almost 50 years for us to be where we are today, because in the 70s, it was something known as unsafe abortion. In the 2000s, it was something known as a safe abortion. And we are now in 2020, 50 years later, talking about respectful abortion care. While we are here, there are several countries which continue to struggle even with the basics related to abortion care and the rules and regulations for it. It's interesting that even today, 2 out of 3 abortions are deemed unsafe in our country, despite this kind of a progress and talking about, making abortions available to everyone. So it was right time for us to embark upon this entire initiative in this partnership, so that we can start orienting our colleagues in the field from various societies to be able to understand, appreciate, and implement, and imbibe all of these virtues and all of these related aspects of abortion care in this thing. Ira, can you mute yourself? Ira, can you mute yourself? Thank you. Yeah, so that's where we come from. Avoiding is the best. Ira, you're still okay. What we would be talking to each one of you today, and the way it is scheduled and taken forward, is we'll be talking to you about the MTP 2021 Act as it has been framed and approved and made available for use in our country by the government of India. WHO has been principally responsible for making sure this hard work went in to see where we are today. Followed by safe abortion technologies and the initiatives there, which may perhaps not be as new as you may think, because a lot of you are already using it in your day-to-day practice, but it's kind of a reiteration of what we are doing and what WHO is prescribing, followed by the SAVOR module, which is a toolkit essentially in terms of building capacities and building that know-how of communication, which is so critical in today's environment, especially when we talk of our country and what we offer to our women. So that's what we're going to talk about. And the last topic today for the day would be pre and post counseling and the aspect related to that counseling. But each one of you are adept with it. So this is not to say, our session is going to be something talking, but it's going to be more realistic. It is going to be more on the ground and hands-on in terms of taking the process forward. We have 3 distinguished faculty with us who will be taking you through all of this. So we have Dr. Achla Batra from AIIMS, who has been conducting and been part of the core team taking this entire program forward. Thank you very much, Achla, for joining us and agreeing to take this process for all the colleagues in the field.
Just to correction, I am from Safdarjung Hospital.
Sorry?
I'm not from AIIMS, I'm from Safdarjung Hospital.
Okay, sorry. Apologies on that, from Safdarjung, which is right across the road. But yes, Safdarjung is Safdarjung.
Yes.
Then we have 2 more colleagues with us who are likely to join in a minute or 2. We have Basab, who is part of the entire Foxy leadership, and of course our very own Parikshit Tank, who also each one of you may be knowing about and have heard of him or have interacted with him at some point in time or the other. So we have these 3 distinguished individuals who will be taking us through this entire program. On certain operational bits, I needed to do that before I hand it over to Achla to walk us through the first session for the day. At the end of the program, that is when the last session is complete, the 4th topic, in the chat box, we will be posting for you a link. When you click on this link, you will be taken to a site which will ask you to submit the post-test and the feedback. Please do not miss that link. Do click on it and ensure that you submit the post-test and the feedback and complete your process of having attended this program. And as per the policy requirement and the agreement with the donor, it is important that all these 4 things are complete. Registration and pre-test is already done, because that's the reason why you're here. And post-test and feedback is what you will get in the chat box. For those who miss it in the chat box, please note that when you leave the meeting, when the meeting comes to a close, another pop-up will come, which will again give you an opportunity to submit the post-test and feedback. So you have the second opportunity there to submit that. And if you miss both the opportunities, do not worry. All those who have missed that opportunity, at the end of the session, maybe in a day or 2, by Monday, Tuesday, another email will be sent to you with the link of the post-test and feedback. So you will have no reason for not having submitted that, and you would have no reason to ask us as to what needs to be done. So please do ensure first the chat box. At the end of the fourth session, you will get that. Then is when you leave the meeting, and followed by an email thereafter. Email will go only to people who have still to complete the post-test and feedback. On that happy note, I also have another operational thing which I want to inform you about. It is related to carrying on this program in your respective societies. It's very critical. If presidents and secretaries are here, please initiate this in your society. If they are not there on this call, all the members from different societies, please make sure that you inform your president and secretary who are already aware of this, that they carry on this program in their respective societies. And on that note, I also wanted to share one last thing for the day, is that each society, we have been able to negotiate a certain honorarium for each society to carry out this program. Not that the society expects it, not that that will be a motivation for the society, but we felt that it was important that if we are able to get some, honorarium for the society for carrying out this program, that should be shared with the society. And that will be coming to each and every society in order to initiate this program and make sure your members are fully aware of what this program is and the wherewithals of the same. So thank you very much for the patient hearing. Achala, it's over to you. Thank you once again for being here and walking us through the first session on MTP 2021.
Thank you, Ajay. So today in India, we are very proud that we are standing tall in the words platform, that we have the most liberal MTP law. So this MTP law was first, in 1971, when it was first introduced. It was because the ways of abortion had become, safer. So this law came into force so that the people don't go to, is my slide seen? Are my slides seen?
Yes, ma'am.
Yeah,
Yes,
okay.
ma'am.
Thank you.
Put it in the slide
Yeah,
show mode, ma'am.
Yeah. So in 1971, when the law came, it was for, because abortion had become safer. And then in 2000, we had a great move by Foxy, for safe abortions. And now in 2021, we have, the amendment, which has made it possible for it to go to more women, more vulnerable women, more groups of women are, even adolescent, unmarried people. So all of you must be aware of these new amendments. Only then you would be able to make use of it. So the first session of this respectful abortion care is about the amendment of this MTP law. And what we are going to do is we are going to take a look at the new laws, and we're going to tell you what are the changes which have been made in the rules. Of course, all of you as practicing gynecologists know the old rules. So, and the need for this amendment, because still after 50 years of having the MTPT Act legally, still unsafe abortion are the third leading cause of maternal mortality. 8% of the maternal death per year are due to abortion. And 2 out of these 3 abortions are performed in an unsafe way. And half of the pregnancy-related death occur in the woman under 24 years, which is really sad. So what is safe abortion, first of all? The definition by WHO, or anyway it is, that it is done by an appropriate method, it is done by a trained person and in an appropriate place. Now, this has been mandated by law, and the changes I'll tell you. Earlier, it was that up to 12 weeks, you required opinion of 1 providers, and you required opinion of 2 providers for MTP from 12 to 20 weeks. Now, the change is that there is only requirement of option of 1 RMP for termination up to 20 weeks. And now it is made legal up to 24 weeks in some special circumstances, and then you require opinion of 2 RMPs. So this has done, increase the number of places where it can be held, because there are many places which are equipped, but they don't have 2 RMPs. They have only one who's quite capable of doing it. So this has expanded the places. Now, like I said earlier, it is permissible beyond 20 weeks also. Previously, it was permissible beyond 20 weeks only when it was necessary to save the life of the people. But this, from enhancement for 20 to 24 weeks for a special vulnerable category of women, which I'll talk about. And also, it has, helped the minors, the rape victims. And we have seen, in newspapers also, we have seen that the people were running, that Nikita case in Bombay, she was running from pillar to post to, get herself an order for termination of pregnancy for a defective pregnancy she had. And ultimately she got the order, but how much effort so now this has made it easier. And previously, the condition of failure of contraceptive was available only to married woman and her husband, which made us, securant that we are the responsible for morality of a woman, or whatever is considered the morality of a woman. And this was not, if she was not married, the failure of contraceptive was not available to her. So now, this condition of failure of contraceptive is available to all women and their partners if they had failure for as an indication for termination, because this will make abortion safer, because people who had abortion, especially if they're not married or failure of contraceptive, they would go to unsafe places if safe places are not available to them. To make the abortion respectful for the woman, to maintain her dignity, now it has become, in the binding of law that the information about her, is not disclosed to anyone except if it is required by the law. And so for that, what is done is that whenever a patient comes for MTP, she is given a number, and from that number only she gets her admission card made, and everything is done by that number. And all the form C and D, they are filled, there the name is written, but they are kept in safeguard. They're not shown to anyone. So that maintains the privacy, confidentiality, and safeguards the rights and dignity of the woman. And it provides respectful care to her. And also when a woman feels respected, she feels that she is, people are being empathetic to her. She will listen to you about counseling and contraception also. So this is a very, very important salient feature of this MTP amendment, and to prioritize the confidentiality and safety of the woman. And we have also ground of failure of contraception has also gone for the unmarried woman. Now, what are these special or vulnerable category of women we are talking about who are extended the termination of pregnancy from 20 to 24 weeks? And the norms, who are the RMPs and who are the people? Now, the law also says that beyond 24 weeks on the ground of congenital anomaly of the fetus, which are such that if fetus is born, will have serious physical or mental disability, with the help of a medical board, pregnancy can be terminated, and there's no upper limit to that. That is one very important aspect of this law. So we will talk about these 3 things. Now, what are the special category of women? One is survivor of sexual assault or rape or incest. Pregnancy in humanitarian ground, like humanitarian ground is like there is a disaster, like we had COVID and people were not able to reach the medical facilities. So they are allowed termination of pregnancy up to 24 weeks. Suppose somebody becomes a widow or she takes a divorce and she doesn't want to continue the pregnancy, she's also allowed. Physical and disabilities also have come in this act now. Mental ill women, including women having mental retardations, minors, or if the fetus has abnormalities which are such that it will be born to be seriously handicapped, also 20 to 24 weeks, it can be done with the consent of and opinion of 2 RMPs, and beyond 24 weeks with the consent of medical board. Who is an RMP? Who can do perform MTP? RMP is a medical practitioner who has assisted in 25 cases of MTP, of which at least 5 have been done independently, or somebody who has completed 6 months of house surgery in obstetric and gynecology, who has a postgraduate degree, or have experience of at least 1 year in the practice of obstetrics. Now, additional category of provider has been added because we have so many medical methods of abortion which are permitted under law up to 9 weeks. So for this, so much expertise is not needed. So there has been relaxation, and RMP with experience in the practice of OBS and gynae in any hospital for 3 months, or has done 10 cases of MTP by medical method under the supervision of a RMP in a hospital who is a training institute recognized for this purpose. So see how much it has decreased the qualification for medical method of that, so that more and more RMPs are empowered to do it. And of course, 1 RMP's opinion is required for up to 20 weeks, and 2 RMPs, like I said, from 20 to 24 weeks, and beyond 24 weeks, you require the permission of a medical board. This is just a recapitulation of what I have talked about. Till 9 weeks for medical abortion, experience in any hospital for 3 months in the practice of OBS and gynae, or independent performance of 10 cases by the medical method under supervision of a RMP in a hospital who is approved for the purpose of medical termination of pregnancy. And all other 3 remains the same. 25 cases, a postgraduate, a 6 months house job, or a 1 year experience. And this is still 9 weeks. For 12 weeks, who can do? Only those, like earlier, 25 cases, a house job in gynae, or a postgraduate degree, or 1 year of practice like we had earlier. From 12 to 20 weeks, now a single person can do it. The qualification remains postgraduate degrees, house job, or 1 year of working in obstetrics. And beyond 20 weeks can be done postgraduate diploma holder after completing 6 months of house job, or a practitioner who has worked in OBS and gynae for 1 year, but it has to be the opinion of 2 RMPs for 20 to 24 weeks. Beyond 24 weeks, a practitioner with a postgraduate degree, or a practitioner who has worked for 1 year in OBS and gynae. And for this, opinion of medical board is required. And the medical board will decide whether this MTP should be done, and whether it is going to be, the indication is correct, and whether it is safe for the woman to undergo. What would be the composition of medical board? Minimum, a gynecologist, a pediatrician, a radiologist, or ultrasound. It has been suggested that whichever place it is being done, the HOD of OBS and gynae should be part of this. At least 1 female should be part of this board. These are just suggestions. And if there are such anomalies for which the opinion of other specialties like a neurosurgeon or a cardiologist required, they should be part of the board. Boards are going to be constituted by the states, and soon, though it is still not there, but soon a list of the names of the boards would be provided so that people will know whom to contact in case abortion is required. Already pre-existing boards are there, but new boards, the government has asked the states, and Foxy is going to facilitate that the boards are formed to for easy access for everyone. So the power of the medical board, I said, would be to allow or deny termination of pregnancy beyond 24 weeks gestation, only after due consideration, ensuring that the procedure would be safe for the woman at the gestation age, and the malformation has substantial risk for it being incompatible with life, or if born, child would suffer from such physical or mental abnormality to be seriously handicapped, and also co-opt other specialties if required. Functions would be that once somebody applies to a medical board, they will scrutinize the woman and her report, and they will provide opinion on Form D within 3 days of the request. And they will ensure that when the termination is advised by the medical board, it should be carried out with all safety precautions and with counseling within 5 days of the receipt of the request for medical termination of pregnancy. So another thing I want to, the consent. Earlier, confidentiality was lost, and the consent for the minors, when they came, they had to bring either their parents or some guardian. But now the consent for a minor can be given by anybody who accompanies him more than 18 years and is willing to give the consent. So there has been a lot of liberalization on the MTP law so as to make it available for everybody, to include the vulnerable women, to increase the places where it can be done. And it is a step forward, but we all also have to realize that we should remain within the law and not perform any unlawful activities. And again, just to reiterate that you have to fill the post-it at the end of all the sessions. Thank you. Now the next session, I will just Bashir, the next session is to be started.
Yes, ma'am. If there is no questions, we can start next.
Yeah. Any questions? Anybody who has any questions can write it in the chat box, and we can. Somebody has asked, what is the status of? Yeah, I think. What is the status of Ayush doctors? So as per the law, we have defined who are RMPs who can perform. So anybody who has a MBBS degree and has all the requisite can perform. This Saver toolkit is would be available on the WHO site. And the program of the Saver, when it is done, it will be told to you. I don't see any other questions. So the next speaker can take over. Somebody has asked how to maintain confidentiality. See, confidentiality is for the person's identity not to be revealed to anyone. But when you're giving the discharge slip, you're giving it to the person. So it is for her, to see whether how she maintains. But when you are not making the case sheet in her name, nobody else can see her name. If somebody is asking for leave, it means the leave is on the ground of MTP. It means she wants that we should inform that MTP has been done. Only then we can give leave. And if somebody is asking for insurance, it means she wants that she has got the MTP done and she wants insurance. So confidentiality is for when she's there with you. Nobody else should know about her if she doesn't want it. If somebody comes, somebody is asked if a under 18 girl seeks MTP advice alone, no. One thing is there, you must also remember that doing MTP and POXO Act are two separate things and both have to be maintained. If somebody under 18 comes with a boyfriend who's more than 18, we can give her the facility for MTP. But under the POXO Act, we have to inform the police that such a girl who's under 18 has come for MTP. Otherwise, we can be in trouble. And it is not necessary that the proceedings would be done, but just the information has to be given to the police. No, the name is not to be, somebody is asked, can the name be written on the OPD register? The things which are outside, we just give them a unique number, and the names, whatever we write, they remain with us in lock and key. But all the or everything for the girl or the woman is done by that number. In computer, we only send them with the number, and on that number only the address is written. If for the computer, we don't send the names for admissions, we only send the number, but we have the record of that number, that what is the name. But when we send to central registry of the hospital or nursing home where you have to write the address, there only the number is given. Does a rape victim need proof for MTP? If she wants, yes, she can be given the proof if MTP has been done. And who can perform abortion? I think I've said many times, a registered medical practitioner who, according to the definition, is somebody who's done MBBS. So they are the ones who can perform MTP. So I don't see any more questions. Somebody has written below 18, if no bystander. What is the meaning of that? I don't understand.
Madam, I have a question. Can I ask?
Yeah, sure.
Madam, the hospitals where we are working, does the hospital need to register for the MTP?
Of course, wherever MTP is done, that needs to be registered under PNDT. Otherwise, you cannot perform, and that becomes illegal. All ultrasounds, MTPs, the place has to be registered, and the information has to be sent. It's just not
that maintained. That
registration part.
And this was about hospitals and nursing home also. Everybody has to.
Everybody has to. Everybody has to. The sexual assault certificate is not required if somebody says the pregnancy because of sexual assault. Two RMPs can opine and perform the MTP. And somebody said, can we do MTP if no bystander? What is the meaning of that? This is Dr. Sheba T. Joseph. Can you?
Madam, if a woman under 18 years comes and she is no bystander, can we entertain MTP?
No, you have to have a guardian more than 18 years of age. Only then you can perform. Otherwise, you can't.
Okay, ma'am.
Good afternoon, ma'am. When patient comes to our OPD, we enter her name in the register as a OPD patient.
Yeah.
How do we know that she has come for MTP? Later on, we come to know that she want to get her MTP done.
See, when a patient comes for MTP, where will she get the MTP? It will be done by a doctor after filling the form C and D. No MTP can be done without filling those forms. When you fill those forms, you know that she wants MTP, and those forms are kept under lock and key, and she's given a number and we perform the procedure on her. So without filling the forms,
at first place, when patient enters our OPD and we enter her name in the OPD register, what will happen to that thing?
So she could have come for anything. We are not writing that she has come for MTP.
Yes.
We are maintaining the confidentiality. Anybody can come to you for any gynae problems. But when you are performing an MTP and on the papers of MTP, where you will do the procedure in the hospital, you will only write the number which you give to, because a number has to be generated by every place where an MTP is done, and that number only has to be written and not the name.
So one register for OPD and one register for generating number.
Yes, definitely. That is how you maintain the confidentiality. Otherwise, you can't.
Madam, if a patient has come for termination of pregnancy by DNC alone, more than 18 years, can she be taken up? She comes with a neighbor or alone, her husband is away.
See, once a person is more than 18 years, all the laws are changed for her. It is only for less than 18 years that she has to have a guardian who is more than 18.
Nice lecture, Dr. Achila.
Thank you.
Hello, can you hear me? Yeah.
Yes.
Dr. Achila, I wanted this saver toolkit because I visited WHO site. They asked that do you have any link or something, some unique number before you can access this saver toolkit?
The saver training would be given to people who want it, and once you have the training, you'll have the link.
So how do I register myself to the saver training?
Which city are you in?
I am from Rajasthan, Bikaner.
It will come to your cities. It's a pilot program at the moment. It will come to all cities. It's going to be pan-India.
So,
from Delhi, if you want, we're going to do a program in Delhi. And since it's a webinar, anybody can register. So you can register from Delhi when we do it.
Okay. You are doing some pilot project for the saver?
It's already been done. Now we have been trained for saver. Now we will do it, for other people also.
Last time I attended this TOT, but that time no saver was done.
Which TOT?
It was like 11th February probably. I attended. That was the last session of training of trainers. Like
for RAC or
RAC. Yeah, it was for RAC.
Saver is a separate thing. Saver is a separate. You will know about it in the subsequent lectures. I will be taking the third.
So why it is so much confidential that you have to have a toolkit, then only you can do it?
No, it's not confidential. It's just that they're starting, Now it will be available everywhere. It is just started, Just few master trainers have been trained.
Are there any plans to have any more TOTs?
Yeah, there would be many more. There would be.
So how do we get it, or how do we
it will be circulated. It will be circulated.
Okay, thanks a lot, Dr. Achila. Yeah, it is so wonderful. Thank you.
Somebody said serial number of MTP and OPD are different. Yes, OPD and MTP serial numbers are different. Yes, all cases under 18 have to be reported to police under the POCSO Act.
Excuse me, ma'am.
Yes.
Ma'am, in MTP register, can we write the details of the patient and keep the register under lock and key?
Yes, that when you fill the form C and D, all the details of the patients are all there. So which can be kept. If you want to keep some record also, you can keep for the procedure and all. They can be kept, but they have to be under lock and key and to be shown to only people if law they are asking for it. It is not open to everybody.
But C and D form we submit in the civil hospital.
You have a copy. Don't you keep a copy of your records? If you want to keep, you can keep, but it has to be confidential, not open.
Yeah, ma'am.
There was minimum. It is also given for induction of labor, in which case the oxytocin pre-delivery is
I think somebody needs to be muted. Dr. Jaya?
Oxytocin alone may not be able to control the postpartum hemorrhage. And there is no dosage, consistency.
Bashir, please.
Hello, can we request everyone to please mute yourself? If not, Shreeman, can you mute them from the background, please?
Yes, everybody except the speaker can be muted.
Yeah.
I
think question answers are over. So,
Namaskar, madam. I'm myself Dr. Rajshri from Kochi. I have one question, madam. This you said in special case, like in case of a widow or divorce, a woman can undergo in the special case only, ma'am. So is the husband's family or husband's consent is not required, ma'am? I just wanted
no, for no MTP after 18 weeks, husband consent is required. A woman has a right to do what she wants, and she doesn't require consent from husband, mother, father, mother-in-law, nobody.
All right.
Whether married, not married, widowed, separated, no consent from anybody is required.
Thank you. Thank you.
And ma'am, for sterilization?
Aren't
we deviating away from
exactly?
This?
Yeah, I think we leave it for the sterilization topic out there.
There's no consent. Woman can give consent.
Yeah.
Good evening,
so thank you so much, Achala, for taking. Other people, can I request you all to put it, Snelata, in the chat box? We'll carry on with the session and we'll keep replying to your questions in the chat box, please. With that, we move on to the next one. Thank you, Basap, very much for joining in. It's such a pleasure to always see you again and again in different meetings and presentations. And I've already talked about you in the introduction. So with that, request you to please carry on with your session. Thank you so much, Basap.
Thank you, Ajay. Thank you very much. Thank you very much. We just are moving on with this session. In the next 15 to 20 minutes, I'll take you through updates in technology. A lot of this you already know, but as I understand, this is something which you will be also relaying and having training other people from here. It's a good idea to just go through the module and see whether you have any suggestions, any modifications beyond what we have already done and fine tuning which is done. I understand that you know that this is a schedule. This presentation comes from WHO India and FOXI, and this is a part of the respectful abortion care. So over the next 15 to 20 minutes, I'll take you through some of the existing guidelines, a pre-abortion assessment, something which all of us do, we should not be very casual about, and the different approaches of abortion which we have, which you are very well versed with, the medical and the surgical, and some fine-tuning regarding that. It's important to understand that whenever we talk about abortion and WHO, these yellow books keep popping up on the internet, and you can free to download them on the WHO website, especially the Safe Abortion, which was first published in 2012, and the Medical Management of Abortion in 2018, which has a lot of information what is required, and also the post-abortion contraception book. So this is the publications of WHO on safe abortion over time. So 2012 was the first one, 2018 was the medical methods, and then there have been other adaptations of WHO guidelines by the Ministry of Health and Family Welfare of India, and that has also been there, and it's all available online. We do not need to really stress for these. And then we also, of course, know about the change in the MTP law. And there is a lot of discussion and discourse, very rightly, on the changes in the MTP Act 2021. So there is a lot of leeway given to the women, and it's a victory for women's rights in a lot of ways. A lot of people see welcome the move of this new MTP 2021. There are some lacunas. Sometimes every law will have some loopholes and some discussion, which of course we have at different sets, and that will also be one discussion here. So all guidelines have three key areas in the management of abortion. We have already said that. It's a pre-abortion care, abortion care methods, and after care and follow-up, including post-abortion contraception and counseling. So the pre-abortion assessment and counseling, the components of pre-abortion assessment would include detailed history take, and that's important because of some of the things in history which will guide us to know whether what the gestational age is. Most important, of course, knowing regular cycles and how this pregnancy came. But besides that, also her medical history, her previous any other problems which may decide on what method may be appropriate for her, and also the deciding of the post-abortion contraception. A lot of stress in WHO has been on general physical and pelvic examination over ultrasonography. So a lot of us in our clinical practice are used to prescribe a sonography in early pregnancy to check the uterine size and to rule out an ectopic pregnancy. But the WHO manual extensively stresses, and we know that it is not mandatory to do a sonography, and stresses on a physical examination, a pelvic examination to assess the size of the uterus. And only if you are not able to do it in the very obese or in the previous scarred abdomen or some other problem, then only would you resort to a sonography. So a lot of stress on physical examination and pelvic examination in the WHO manual, which is a practical solution, but a lot of us in clinical practice do that extra sonography to be sure. But again, you can be sure also here. Then the lab investigations, some of them, and then the decision making. So this is the different sizes of the uterus as it's more than 12 weeks when it comes out of the pelvis. You can feel it very nicely alone. And then as it grows up, this is usually for the healthcare providers. And there are limitations to the dating of a sonography if they have fibroids, if it's malformed, multiple cells, you will not be able to antivert it, and if it's obese or there is a molar pregnancy. But of course, we know the commonest reason for wrong size of the uterus is wrong dates. And if the woman has the wrong dates, then that is something which is the reason why it may not match, the uterine size may not match to the period of amenorrhea. And there are other issues also, something with the pregnancy may not at all be there. Then you really need to see whether the pregnancy kit was positive at all and when it's an ectopic or abnormal. So there are issues which need to be sorted. Pre-abortion investigations, routine labs are not a prerequisite, but it is a good idea to have the blood group tested. So the blood group and RH testing is universally done, along with a hemoglobin or a hematocrit for suspected anemia. HIV test and counseling, STI is also, these are some things which are suggested, not done in a routine practice, but in routine, I think the hemoglobin and a blood group is something which would be most appropriate to be done in most cases. RH negative, so if it's RH negative mother, then she would be needing the negative RH immunoglobulin depending on what is available, the 50 or the 100 or the 150 dose, less than the 300 regular, but if you're not getting any dose, then you can give the 300 to her too. Pre-abortion counseling. So again, I think all of us do this in clinical practice, but it's just to put it into a piece of paper and a draft so that it's easy to present to people and they can relate to it. So whenever a woman comes to in the clinic with a request for termination, the first reason would obviously be why and whether it was an unplanned pregnancy and whether she wants to change her mind and to give it another thought. I think that is something which is universal. All of us do that. And that is something to give her some more time to make her decision before we go on to give her the medicines or to offer her the choices which are there. So we all know that earlier abortion is a safe abortion. It all depends on the available methods which you have. Risk and warning signs associated with the abortion method should be shared with her, because once they know the types of abortion, what she's eligible for, then you can discuss the medical versus surgical, the different advantages, pros and cons of each, and she can make an informed choice of what she wants. But also there's a discussion about a contraception. which should go on very early, because if she had this pregnancy because either she was not using contraception because she didn't know about it, or she was using ineffective contraception because she was not she was using maybe coitus interruptus or the rhythm method, then it is a time to counsel her and to tell her that this is something which she can avoid if effective contraception is used, or the chances of an unwanted pregnancy can be minimized. So this is a chance, of course, to talk about contraception, and you just cannot miss out on that. It has to be there. But this is also an important point, that even if she's not willing for contraception, she has to be accepted for the abortion services. The ultimate decision is hers. In her best interest, you'd like to discuss it and make sure that she chooses the method before leaving the clinic. But at the same time, it is her decision. There are some women we know in our clinical practice who are adamant. They go for abortion after abortion after abortion, and that is not in their best interest. Sometimes it's our failure to be unable to convince them to use an effective contraception, but sometimes it is also on them. So the clinical management of abortion, less than 12 weeks, it's a global recommendation of mifepristone and misoprostol. In certain countries where mifepristone is not available or not licensed, they are unfortunately have to stick to misoprostol alone. For us in India, we are lucky to have both, and vacuum aspiration is one option. If it's more than 12 weeks, again, you have the same options, and dilatation evacuation instead of a vacuum aspiration. So Government of India, medical is available until 9 weeks only. And this is what is the schedule which all of us do maintain. We'll come to it in a moment, where you have a 24 to 48 hour gap between mifepristone and misoprostol. And once you confirm the gestational age, and this is what you offer, and the misoprostol can be given in 3 routes, which are most effective: sublingual, buccal, and vaginal. And we'll come to a little more detail on each of them. So the first trimester could be medical or surgical, and we know the way it acts. Mifepristone is an anti-progestogen, inhibits the action of progestogen, and is given for termination, not just in the first trimester, even in the second trimester, or for an intrauterine death. If you want to terminate the pregnancy, sometimes you give mifepristone before giving misoprostol, because it helps in acting better. So it interferes with the continuation of a pregnancy, and it's followed by a PGE1 analog misoprostol, which causes cervical softening, uterine contractions, and expulsion of the products. The advantage of misoprostol, we know it has dramatically changed the way we practice gynecology and obstetrics over the last 2 decades from the time it's come into the picture. And it is extensively used in cervical priming, sometimes for labor inductions, often for PPH, and also here in abortion. So the use of misoprostol has been extensive in obstetrics and gynecology. It's easy to use, easy to handle, non-invasive, cost-effective, stable at room temperature, used in various doses. And it's a good idea to know the pharmacokinetics of the various doses, when does one work. So sublingual is the one which works fastest, but again, the action goes up the fastest. Vaginal buccal is the one which has a prolonged action. Oral takes a little more time to act, and it's really wonderful for low resource settings. So this is what happens: the day 1 mifepristone, day 2 and day 15 follow-up. Though sometimes in clinical practice, we know all this gets combined into one, or sometimes you don't have the chance of coming up again, but it is standard to understand that this is the most preferred regime, where a woman comes on the first day, you evaluate her. If it's you give her the mifepristone, ask her to come back in day 3, then have the misoprostol, sublingual or buccal or vaginal, and then give it the antiemetics, analgesics, and the contraception, and day 15 for a check that it's all done and well in place. So oral pills are okay till 7 weeks. If it's 7 to 9, they say it's better to have a sublingual or buccal. So this is what is done, is either the pills are put under the tongue or between the gums. So I think this is a good the placement of the buccal. That's between the gum and your teeth line there, and here sublingual under the tongue. And this is kept for roughly 30 minutes, and then the woman is asked to swallow. So you can tell her that it's not a mouth-dissolving tablet. A lot of people think that it's tasty. It's not tasty. It's actually will be tasting very bitter, and possibly people may not be able to keep it for more than 15 minutes, but the preferred time is 30 minutes. And there are more side effects because it acts more functionally. So you may have more fever, chills, diarrhea, but all it's temporary, and generally it does not last long. You may need some amount of medicines to take care of that, but generally not. The other thing which standard a lot of us do give is to give antiemetics before giving misoprostol, which again is fairly standard and which is acceptable way of doing. If it's vaginal, it should be in the vaginal fornices, and the woman is expected to lie down for 30 minutes because if she walks around, it may fall off. So induced abortion less than 20, this is what we're sticking to. So we're not breaking up into any more parts, trying to make it simple. So if it's less than 12, we 200 mg mifepristone and 800 misoprostol straight. This is what the WHO says. The government of India breaks it into parts, but this is something which you can use when we have both the things. Because only misoprostol, that would be separate, but this is what we stick to generally. And about vaginal bleeding, I think it's important to counsel the woman how long she may have bleeding. On an average, it's 3 to 5 days, 7 to 10 days, but 2 weeks, up to 2 weeks is okay. And the evaluation of whether the abortion is complete ideally should not take place before 15 days. There was one time when medical abortion first started and people were very fidgety, and people were just wanted to do sonography after 5 to 7 days to see whether the medicines have worked. And a lot of abortions which would have anyway have been completed were all termed as incomplete and were surgical evacuation was done early. That was early days of medical abortion, but since then we have been much more wise. And generally in most situations, we can wait for 2 weeks before we take a call on whether to do a sonography to see if there's any retained products. So provision of medical methods of abortion services, it should be available at the primary care level with referral services. Additional services may be needed to individuals seeking medical abortion, and this would include counseling and testing for STIs. So we know in India, several of our public health interventions are opportunistic. And so you have an opportunity only when the client or the patient who you would call or the woman presents herself to the healthcare services. So when she comes here for one particular thing, this is a chance to check for other things as well. So this is checking for STI, abuse services, psychological effects, and whether she's anemia, whether all this can be done at the same go, so that she has several things taken care of her at the same visit. So follow-up care, routine follow-up is not necessary following an uncomplicated medical abortion, as we often see in our clinical practice. Even if you ask women to come back and you give them the full pack in the beginning, they may not always come back to you. So it's a good idea to discuss contraception and possibly prescribe contraception when you're giving it at the same time, but also tell her the warning signs of things which may go wrong or which may happen where an evaluation becomes a compulsion. But if it's uncomplicated, then she can just keep you informed that things are all right. Follow-up visits 7 to 14 days, mainly to because everything may not go down at one visit. So discussion on contraception, counseling, and everything may be too much to gulp in the first visit. So you may need to space it out by a couple of weeks, which would definitely be accepted by a lot of women. Access women's recovery and ask her for symptoms of recovery. That's when she comes after 2 weeks. Review any medical records. Of course, you have to fill up the documents, Form C, Form I. I think we have re-stressed that from the MTP committee. Dr. Bharti Maheshwari, Dr. Shamal Sheth, Dr. Kiran Putakoti, Jaydeep Tank, all the chairpersons of the MTP committee over time have stressed and re-stressed that Form C and Form 1 have to be filled for any abortion done in the country. It means only things which are out are incomplete, missed miscarriages, ectopics, and molars. They don't come in, blighted ovum, they don't come into the picture, but everything else where an MTP is done, forms need to be filled, whether medical, whether surgical. Ask about any symptoms she has since the procedure. Focus physical examination for complaints. Again, WHO stresses on an examination after 2 weeks to see whether the procedure is complete. So complete eligibility, this is again the same thing which we are going through. There's just one more point that 3% women may expel completely after mifepristone alone, but the schedule needs to be completed. So you just add a little sentence there when you're doing the counseling that even though bleeding may start, so 15% women would have bleeding after the first tablet, 3% would complete the miscarriage after the first tablet, but still she goes on with the full schedule as is described. And the warning signs, as I said, if the bleeding is prolonged, if she has dizziness, if she has giddiness, if there's no bleeding after 24 hours after misoprostol, no bleeding at all, then there is reason to come back and to report to things. So ibuprofen 400 is a wonderful analgesic to take care of the pain. It is invariably present. There's almost no woman who hasn't said of pain. So sometimes we give her analgesics. Most of us in the clinic before giving the misoprostol or give it at the first visit. So antiemetics and analgesics are often accompaniment of the medical abortion medicines and the contraception. I think these three things are most of us would follow. So day 15 pelvic examination to assure that it's complete, all of it, and the follow-up methods. So the hormonal methods can actually be started at day 3. That's your oral contraceptive pills, condoms, of course, anytime. IUCD after day 15 when you confirm that it's clear. And as to stress on the immediate return of fertility that she may go in and have this. So side effects and complications. I think it's important, again, as we said, to be respectful, non-judgmental. So this is a woman who you may have counseled about contraception a couple of weeks ago, and you've told her everything which you need to tell her. She's nodded her head, said she'll think about it, goes home, and then promptly gets pregnant and comes back to you for medical abortion. Now, that's all wrong. Again, you are not, as a doctor, as a professional, supposed to be very upset and shout to her, what did you do? Had you listened to me, you wouldn't have been in this place. Well, that isn't exactly for us. At this point of time, you need to be sympathetic, compassionate, and to tide her over this crisis. The very fact that she's come back to you even after she didn't follow your instructions means she respects you and she values your advice. So it's good to have some important hand holding at this time. That's what respectful abortion care is all about. So you need to be supportive. You need to guide her through this situation, and again counsel her back that this is not in her best interest, that she can have a regular form of contraception. So some algorithms out here. If it's a failure, you can have a repeat MMA, but most would offer a vacuum aspiration. And if it's an incomplete, then again, a repeat misoprostol could be offered for people who are very hesitant to go for surgery. If it's a heavy bleeding, of course, there's no point waiting. But then there's also the surgical option, which one person can go when it's an incomplete result, which will be seen in around 15 days. So here's another algorithm which we have put out for you. If it's excessive bleeding, what does that mean? And excessive bleeding would be defined as 2 pads in an hour for 2 consecutive hours. If it decreases, that would have been the heaviest part, and then if the vital signs are fine. And then if the POCs are in the cervical canal, a digital evaluation, if she's in the clinic, and then it reduces, and then she's fine. If the bleeding decreases over time, it's all right. If it doesn't decrease, then only all this. And if she's stable after that, then nothing to do. If she's still having bleeding continues, then a sonography to see whether she's got retained products, and then to decide on whether to go for a medical or surgical. More of us would do surgical. And if the pregnancy is continuing and nothing is happening, then of course it has to be a surgical. So as we said, Form C, Form 1, Form 2, Form 3, it has to be filled, and those are the things. There's no shortcuts about that. And MMA comes under the purview of the MTB Act, and documentation is similar to the vacuum aspiration procedure. You have to fill all the forms in the medical method of abortion. If you don't do that, and if something goes wrong and you're pulled up, there is no excuse. Methods of first trimester abortion are just to take a little bit from MMA into surgical. The vacuum aspiration is the most preferred technique. It could be manual or it could be electronic. And manual is one of the safest, and WHO also recommends this. And a lot of us have been used to using the dilatation and curettage, and we always try to think that the curette is the best and there's nothing like it, but unfortunately that's not true. Manual vacuum aspiration has been shown to be much more safer. And this is how it looks in case you don't use it. A lot of medical colleges use it. In the private sector, there are not many people who use it, but I think it's something which is the safer and has to be very much promoted. IPAS over the last 2 decades has done remarkable work in MVA awareness around gynecologists, and to help to disseminate the guidelines and the evidence regarding MVA. The other option is electronic vacuum aspiration, where you use an electronic pump. Again, the problem of electricity in places where it's not there. Cervical priming before a surgical method of abortion is almost standard now. And so you can give it a sublingual 2 to 3 hours prior to the procedure, and when she's waiting in the clinic, possibly. And also it could be administered vaginally if she's already admitted there. Laminaria is hardly used now. And pain management, as we said, so whether it's a surgical or whether it's a medical, you must look into pain. Non-pharmacological ways of controlling pain are your body language and the way you talk to her and the counseling. And of course, the pharmacological, we said about ibuprofen. Psychological support is so important, and to explain the woman through it and to understand that she is a woman who's come in distress and you need to tide her over this crisis before you take the discussion forward. So anxiolytics, general anesthesia, different ways in which we can look at it. Diazepam, these are cervical dilatation. You can use lignocaine. Generally, effect will be for an hour, and ibuprofen. So I think the least which we can do is by a paracervical block, and we'll come to that. So MVA, how the instruments are prepared, I think that's a small demonstration which we reserve for usually workshops. Prepare the woman for pain and empty her bladder, perform cervical antisepsis and the paracervical block, as I've done 3 o'clock and 9 o'clock. Dilate the cervix, insert the cannula, suck out the contents, withdraw the cannula from 1 to 2 centimeters from the fundus so that you get a clear space, rotate it in a gentle motion, and then release the vacuum button on the aspirator so the things sucks out. So you need to repeat it a few times. Sometimes a red and pink foam without the tissue passing through the cannula, gritty sensation over the surface of the cannula, cervix gripping the cannula are some things which should be there when you ensure completion. So inspecting the tissue, concurrent procedures if you need to do it, and of course the instrument processing, which you should be familiar with, especially if it's a small nursing home, a small hospital, and you're doing it, it needs to be seen that it's disinfection is complete. Post procedure, if it's a surgical surgical abortion done, you have to look for any other complications and make sure that she's comfortable and her vitals are stable when she's leaving, and she's got all the necessary information and the medication. Some of just to now, following the procedure, and some in the long term, especially in the look of contraception. All the documentation needs to be done. And again, patient privacy to be maintained. You can't put the name there. Management of abortion complications, incomplete infection, ongoing, and the contraception, as we said, and SRH, sexual reproductive needs, if any, need to be addressed. So in summary, India has made historic progress in improving the access to safe abortion. So making abortion safe, one of the big reasons is technology. And with the medical methods in the picture, and 80% of people opting for medical, more than 80, then that is one of the ways in which abortions have become safe. But also the use of MBA, the use of has been much safer than the curettage. Not much has taken the technological update in the last decade, ensuring safety and quality, especially in the context of the amended law, using respectful abortion services and equipped with the proper information. Thank you very much. I'll just run through some questions if we have any. There is something in the chat box. I'll just run through that. It was something from Dr. Achila. When can we do sterilization after providing medical abortion? Medical abortion, sterilization can be done at the same time. I think, no, not same time. Usually after a couple of weeks, you can do it almost any time. It's nothing specific regarding that. Can patients send back after mifepristone in the second trimester? I'm not sure what that means, but I think whether mifepristone you give her, you send her back and then call her back for misoprostol. Yes, you can do that, unless she's bleeding actively and she needs incomplete abortion. Okay, Dr. Achula has already answered that. And post-cesarean section. Post-cesarean section always is a problem. Any scarred uterus, you need to be careful while doing it, depending on the size. A post-section at 16, 18, you have to be more careful. No specific WHO cutoffs about how is the thing. Paracervical block in PHC setting, it's very safe. That's the safest compared to a lot of other things. So I think that's something which is most recommended. MTP pill without prescription from the pharmacist, very, very common thing. But again, it's not a topic of discussion here. We know that it exists. We know when we can't keep ourselves blind, it's an elephant in the room, where you know that a lot of over-the-counter MTPs occur in India. There's a lot of evidence to suggest also it is. We do not encourage it as a responsible medical organization, but there's not much you can do for it. Again, it's patients' rights about whether patients will pick up medicines from where they want, and it's not. There's nothing we do to change that. So there's not much we can do there. But there is definitely some organizations looking towards pharmacist training, some organization looking towards making it safe, talking to them about it. But generally, the normal feeling is that a very little damage can be done with a medical method of abortion alone, compared to botched up medical abortion is less likely to have a very significant effect than a botched up surgical abortion. MTP in a small nursing home with only minor OT, do we need to register? Of course, any MTP in any place, you have to register under the MTP. There's no question about it. So MTP, unless you register, you have three things now, either the doctor and the place. You have to register. It has to be there. There's no question about it has to be registered. So that is, so only thing which you can do that you can do medical method of abortion without registering, where you need to have the board, where you need to have a mention that you're attached to a hospital where you will take care of her in case a surgical problem is there. But medical methods of abortion can be done in a small place, in a nursing home, which doesn't need to be registered. The person needs to be registered who's doing it, of course. It can't be done, and they have to have a referral contact. MTP sterilization can be done as per as the Act. Yes, I think there's nothing to do. A lot of times surgical MTPs and sterilization are done together. Standard method for more than 12 weeks. Standard method, I think there's no standard. You give them the options, but usually mifepristone and misoprostol is one option. Other option is suction evacuation dilatation period, because suction will be difficult at 12 plus weeks. Lap TL done with first trimester MTP. Yes, it can be done. I think the tube will be a little more vascular, but I don't think that generally is a problem. Failed medical abortion or incomplete, do they need to register in the center? No, that's not when they come to you after doing it outside. This is a common question, because by the time it will be incomplete. No? So by the time it comes to you with half bleeding and not, then it's incomplete. But if you are starting it again, or failed medical abortion, incomplete you don't have, but failed medical abortion means it's a live baby, you've done a sonography and you're giving fresh medicines. Of course, in that case, you need to register them. And repeat MMA, an interval of first and second one. Repeat MMA, there's no repeat MMA. Ideally, it should not be there. So there's no, ideally, you keep count. Again, the same thing as we discussed, you can't have abortion after abortion, but at the same time, you need to counsel them that it needs effective contraception. It should be encouraged. So there's no interval as such between medical abortions. Ideally, you shouldn't be having too many, because you should be using some contraception. Thank you. I think I'm done. Ajay, are we back?
Yeah, that's wonderful. Thank you so much for taking in all the questions and, in one breath, almost replying all of that. Talks a lot about the kind of command and, the knowledge base that you have for this program. Thank you so much once again, Basab, for being here. We move on to Achala for the third session, which is a Saver Toolkit. Thank you so much once again, each one of you.
Okay, thank you.
Achala, I may just have to step out to another meeting. After you complete it, just hand it over to the next person, which is Parikshit. I've already introduced him earlier.
Okay, I'll do that.
Thank you so much. Yeah.
Okay, so now after a lovely talk by Dr. Basab about the methods, now we are on to the respectful abortion care, the SAVER module which WHO has. SAVER is a acronym for Safe Abortions, Value, Evidence, Right, or Respect. This is not something which is given in books. Like we have respectful maternity care, this concept of respectful abortion care has also come. And when you say respectful abortion care, it doesn't mean that you talk to the patient nicely. It's also providing abortion safely. Everything is included in that. But this saver module is not for the patient. It is for the provider. The module aims to change the biases of the provider towards the abortion seeker. It seeks that when you are providing abortion, you provide it to the woman with dignity, maintaining her autonomy, maintaining her respect, so that she is receptible to you. She listens to you, so you are able to give her advice about contraception and how to prevent future unintended pregnancy. So basically, this is a very, very interesting module in which is not only lectures, there are a lot of interactive games and all, and there are a lot of videos in it by which, when you interact with each other and with the facilitators, automatically your values change. So I will just make it slideshow. Yeah. So in this module, we will define respectful abortion care, what is the WHO standard, and we'll talk about how our norms and stigmas, they affect the abortion services, and how saver resources can be useful in comprehensive abortion care. Now it's the time when the law has changed and we have become more empowered to provide abortion singly. There is online training which is possible, so we can reach out to everybody. We have medical abortion available, which is early, safe, but of course we have to ensure that we do not conflict with PCP-NDT, and we have to realize that patient safety, respect, and quality of care matters more than ever, because we have an important role to play. A respectful abortion care refers to the care that maintains the safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all type of abortions. Whosoever is seeking it, whatever age, whatever ethnicity, whatever religion, whatever is her obstetric status, nullipara, multipara, grand multipara, means we treat the patient with respect. We can be the seeker sometime, maybe not us directly, a relative or somebody. Then we would, want that the person should be treated with dignity, empathy, and compassion. And of course, if there's something wrong, then we must speak up also. But we must listen also and support. And respect's always biggest respect. When we respect a patient, patient would respect us. Patient would put, confidence in us, and patient will listen to what we say. So there's a small video about what are norms and stigmas, which will tell you that what exactly, how they affect.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors, like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
So we saw in this video that there are norms and stigma, and definitely norms and stigma do affect how a provider is behaving with the abortion seeker. I think you all must have experienced a sixth gravida when she's coming for an MTP. You would be, why she has produced 6 children, why did she get pregnant at all? Or an unmarried girl, you will look at her with, why she is immoral, and, sometimes people would even talk to them. This is kind of, showing disrespect to them and abusing them. The disrespect and abuse you can categorize into 7 kinds. Physical abuse, of course, that is not done so often, but it should not be done. Verbal abuse, yes, we do it very often. Sometimes because of the rush, sometimes because the patient is coming again and again, and like I said, there's a multi is coming, so we condemn them. Sexual abuse is taking advantage or abuse of power. This we have to speak up for that. That is why this POCSO Act is there, that we have to inform whenever there is a person below 18 who has come for MTP. And then stigma and discrimination, which we talked about, about grand maltese, unmarried girls, a widow or out of marriage relationship and seeking abortion. So we have that stigma and we discriminate. And then the disrespect is not only this. Disrespect is when we fail to meet the professional standard of care, the safe abortion, person, place, and technique. If we don't do that, that is also a disrespect. When we do not have a rapport with the woman, that is also a disrespect. That is not safe, because if you don't have a rapport, you will not be able to counsel her, and the condition of the constraints of the health system sometimes also are a kind of disrespect because they're not able to provide proper services. So the respectful abortion care is that you do no harm or mistreatment to the woman. That is a part of safe abortion. You have to maintain privacy and confidentiality, which even a new amendment says. We have to preserve dignity of the woman. We have to respect her choice, what she wants. Suppose a woman has come for MTP and she does not want contraception. You can counsel her about contraception, but even if in spite of your counseling, you are not able to, motivate her, but you must provide abortion. It can't be that MTP has to be like so many times in public sector. प्रॉपर्टी लगाओगे तो एमटीपी होगा, नहीं तो नहीं होगा. डीएमपी लगवाओगे साथ में तो होगा, नहीं तो नहीं होगा. We have to respect the woman's choice, but if you have a rapport with her, she would listen to you. So we have to have engaging and effective communication with her, and we have to provide information to her, what will happen to her and what is available for us to give to her for not having her unintended pregnancy. And also the support has to go beyond the providing abortion also. It has to be a continuum. And of course, we have to maintain the quality of the physical environment, and all the resources should be there for providing equitable abortion care. And the provider also should be competent as well as motivated, and provision of contraception advice should be there. And of course, post-abortion care has to be there. So only if when we provide respectful abortion care, we will be able to implement safe abortion. And this has already been talked about. One provider is there for abortion up to 20 weeks. So we have more responsibility of counseling, contraception, referral, and compassionate care. And for 20 to 24 weeks, we have to be very sensitive, non-judgmental, and should be providing free timely services. And we have to respect your abortion seeker and not get carried away by the socio-cultural aspect of. So there's some languages which we use, which we may not know that they are stigmatizing. So there's a small video about that, which will tell us what are these languages which we inadvertently use sometimes.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, It is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework, but may be safe if performed by a trained provider or when a person has access to high-quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 Ps, provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
Another video about Saver Toolkit.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Saver, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Saver Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort. Saver has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Saver is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So this is just a small trailer of Saver. When we say engage, it means we talk about some media stories and then take opinion. That say there was a abortion in Hyderabad of a school girl and who almost bled to death, and media blame the doctor. So this is how everybody gets engaged, and Inform is, of course, providing the data. The most interesting is the Explore, in which, a lot of games are there. Say there are 20 people, so they are standing in a line and one question is asked, and then they go to either side of how they food. And then the facilitator, the person will tell, what is the correct answer and why it should be correct, so that after discussing with everyone, the values, the biases, they change. So now I'll just play a small game with you. I'll ask you some questions and the answers can come in the chat box. These are the games I was talking about, which are there in the, and these are the resources. Somebody was asking, you can note down, these are the resources for these games. So according to the World Health Organization, restricting abortion care access reduces the number of unsafe abortion. Is it true or false? I would want the answer in the chat box. So I see the answer as false. Everybody is saying false. So very good. Because if we restrict, of course, we will not decrease abortions. Then the next question is, why it is not coming? The next slide is not moving. What can I do, Bashir, to make it move? Hello? Yeah. According to World Health Organization, this we've already had, because WHO says that safe abortion is by method, by person, and a place, doesn't talk about restriction the access. The MTP Amendment 2021 requires a minor less than 18 years to get a written consent from the parents and guardians before she can undergo a termination of pregnancy. So, true, false? I have so many truths. I think we very clearly discussed, and we had question answers also, that a woman does not require a consent from a parent or guardian. She only requires that she should have somebody with her who's more than 18 to give the consent. A consent from the guardian or parent is not required. I think somehow I failed to, even after so much discussion, this message has not gone. Yeah, now we're getting false. Yes. Again, it is stuck. We have answer from everybody. Still some truths are coming that she requires consent from a parent or guardian, which is not correct. Bashir, why the slide is getting stuck? Can anything be done about it? Okay. So again, to reiterate that you have to report a person coming for abortion under 18, but we don't require the consent from parent or guardian. A 30-year-old woman who has recently widowed wants to get an termination of pregnancy at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? So we have got this correct. Everybody is saying no. So which is correct. We are nobody to tell her that she has to keep, and in fact, her in-laws or her parents, nobody can tell her to keep. If she wants to keep, is her wish and her decision that she has to continue her pregnancy. And under the new amendment, 2 RMPs can, give opinion that, and it can be done. I think that's about the end of this Savor module. And again, want to reiterate that after the last lecture by Dr. Parikshit Tank on the counseling pre and post contraception, you have to fill that feedback form. So after, so if Dr. Parikshit has joined.
Yes, I'm here.
Yeah.
Hello.
Hello.
Good evening. Good evening.
I think everybody knows.
वो उसके साथ ही को दे दूँ, वो कम लग रहा है, बता क्या करूँ?
Please mute yourself.
Doctor, yes, thank you.
So you've already been introduced, so I think
I'll just go ahead
yeah.
and get things going. Thank you so much. It was really it's been a wonderful session. I've been fortunate to be a part of this set of programs, and really respectful abortion care is a topic which President Dr. Shanta Kumari has taken to heart, and I must thank her and the Secretary Dr. Madhuri Patel, of course the people involved from WHO, Dr. Chaudhary, Priya Karna, and I would be failing in my duty not to mention Ajay. I mean, he's been really a pillar of support for these programs. And let's get going with the topic that has been assigned to me, and that is pre and post abortion family planning counseling. So, when we talk about respectful abortion care, then counseling is an absolutely integral part. Communication is an integral part of that entire process, because respect comes from communication, and communication begets respect. Without each other, it's not going to be a complete and holistic approach. So we realize that counseling is not something like a chat. It's not just talk. It's a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. So please, I would really, I mean, each of these phrases has meaning, and each of them emphasizes the entire aspect of respectfulness that we need to establish in our practices as far as offering abortion services is concerned. So it's as important as the procedure. The woman may need help in decision making, whether she should stop the pregnancy or not, whether she should continue, what kind of abortion she should have, the modalities, when she should have it, etc. So all these aspects will have to be addressed in the matter of counseling. And whenever it is required, the counseling should be broadened. It should be offered to the spouse as well, so that they can come to a decision as a couple rather than she feeling isolated. So when we are talking about, what are the critical roles that pre-procedure counseling is going to have, it's going to be a aid. It's going to be to help the woman to decide whether she should terminate the pregnancy or not. Of course, ultimately it is her choice, but sometimes some medical inputs she may want about her condition. What is the prognosis of the pregnancy? What would happen in the future if she terminates this pregnancy? So this kind of information may be needed. So she will need help to decide about it, the type of method And it's our job to ensure delivery of the complete information about the procedure and ultimately to help her to reach a conclusion as to what the best contraceptive option would be for her as well. So what should be the counseling process like? Well, it should be done in a private and confidential manner. The counselor or the service provider should be non-judgmental and sensitive, and having established a rapport using simple language, the woman should be allowed a dialogue to clear her doubts, her questions. However naive it may sound to experienced providers, this is the need what she has, and it needs to be addressed. So if she has made up her mind about the termination, then assessment also goes into this pre-procedure counseling. Now, this is a very, very crucial time as far as counseling regarding contraception is concerned, and the relevance of peri-abortion family planning service counseling is that there is a quick return of fertility after the abortion is completed. It's an opportune time for contraceptive acceptance because women are in need of that service at the moment. There should be at least a 6-month gap before the next pregnancy.
And sorry to disturb, sir. Signs
Yes.
are not changing, sir.
Oh, okay. Fine. I'll stop the share and then I'll start again. Thanks for letting me know. I was under the impression that it was visible. Okay, what can you see now, doctor?
Yes, sir. Now we can see the relevance of peri-abortion family planning counseling.
I'm so sorry. I think some of the earlier slides might have gotten missed. I'll just run through them quickly. I won't repeat myself. So that was about counseling, how pre and post abortion counseling is integral, what's the critical role, and how the procedure of counseling needs to be done. And this is, of course, coming to the relevance or the importance of peri-abortion family planning counseling. So when should family planning counseling start? Well, it should start at the first contact itself, at the first consultation. There could be some exceptions. So, for example, if a woman is terminating the pregnancy for an abnormal fetus, then maybe one needs to be a little sensitive and address this matter a little later in her course of, in her clinical course. But in most circumstances, it should be at the first contact itself when we are offering the termination of pregnancy. What should we counsel about? Well, we need to tell this couple, this woman, that fertility will return quickly. So there isn't much time to waste as far as adopting contraception is concerned. And we need to help her to make choices, talk about the specific methods so that she gets the relevant information and comes to a decision, and discuss high-risk behavior wherever that is appropriate. Now, I think this has been emphasized enough through this session, and Dr. Batra also addressed this problem that if a woman is not willing for a contraceptive method, that is not a reason to deny her a termination of pregnancy. And this might have happened in the past. This happens at, the best of public institutes, but let this not be a trend which continues. And these two things, the service provision of pregnancy termination and her acceptance of contraception, they need to be dealing. The woman needs to be offered the service, and then she can make up her mind and choose the contraception. You try and counsel her about the procedure, and if she's not willing at that particular time, do give her another appointment, do call her again, so that she has some time to think over it, and then she may be in a more suitable frame of mind to adopt the contraception. So how should you assess that this woman is ready for contraception or further process regarding contraception? We have to ensure that she is healthy, there is no existing infection, and the abortion process is complete without any injury to the genital organs, and see that there is not a very long time which has passed between the termination of pregnancy and the visit, which could be probable, a blind spot, and a fresh pregnancy might have started. Post procedure, again, one needs to talk to the woman about the precautions and care. It's again an opportunity to counsel for contraception and reinforce the need for continuing with the contraceptive method which has been chosen. Now, as far as the post-procedure counseling is concerned, continue to ensure her privacy and confidentiality, reassure her that help is available in case there are problems, and emphasize on the danger signs and signals which would help her to seek care early in case there are problems. If we are talking about the family planning part of the counseling after the procedure, then if a woman has already opted, then appreciate that decision, because this will give her a positive feedback, and immediately we can proceed with introduction of an intrauterine device or administering a Depo-Provera, medroxyprogesterone acetate. She can resume the pills. The follow-up protocol needs to be stressed, as does the continuity, and you can give cards or reminders which would help her to adhere to that contraceptive technique. If she's undecided, then it's our job to allay her anxiety, discuss what is stopping her from adopting contraception, emphasize again the need for early adoption of contraception and the extended period of adoption, adopting a method. Couple counseling is useful, and in case the woman is still not able to reach a decision, it's useful to provide emergency contraceptive pills which can lower the chance of a future unintended pregnancy. Now we'll go through all the contraceptive methods and their relevance and their use in the post-abortion period. Condoms after a first trimester abortion, as soon as sexual activity is resumed, as is for the second trimester. We know that this method is a barrier method without any hormonal effects. It's easily available and protects the couple from sexually transmitted infections and HIV. And it allows men to take responsibility for the contraception. So this is something that can be offered, but let's remember that it's not a way to brush off our responsibility of offering more sure methods of contraception. We have the intrauterine device, and after a first trimester abortion, it can be inserted immediately or up to 12 days after a complete abortion has been done by the surgical method. If it's a medically managed, then inserted around 15 days after the process, having ensured that the products are expelled. Second trimester, either immediately or within 12 days. And we all know that this additional information, which is very, very useful, that it's highly effective, and it is an opportunity to provide long-term spacing method. A variety of cadres of healthcare professionals can provide it. And when it's removed, there's a very quick return to fertility. The oral contraceptive pills after a first trimester abortion can be started immediately or up to 7 days after the abortion having been done by a surgical method. If it's a medical method, then on the day that misoprostol is started, on that day itself, you can start oral contraceptives or within 15 days. Second trimester, immediately or within 7 days of the abortion. And we all know the myths that we need to bust with the use of oral contraceptive pills, emphasize on the many, many benefits that the oral contraceptive pills have, and dispel her wrong ideas or notions. Of course, the counseling about side effects should be there, but it should not overwhelm the discussion about oral contraceptive pills. Long-term injectables, that is medroxyprogesterone, can be given immediately or within 7 days of a surgical abortion, and with an MMA on the day that misoprostol is administered. Second trimester, the same, immediately or 7 days later. Again, an excellent method which is highly effective, does not require any skill or any expertise, just a simple intramuscular injection, and it's a great method for people who have contraindication to the use of estrogen. Female sterilization can be performed after an abortion in the absence of infection or severe blood loss, concurrently or within 7 days. If it's medical, then it can be done only after the first menstrual cycle. So there is a bit of a caveat that we need to follow over here. Second trimester, mini lap can be performed concurrently or up to 7 days. Laparoscopic sterilization after a second trimester is not recommended. A vasectomy, of course, can be performed at any time. It is independent of the process of abortion. These are, of course, complete and permanent methods. This needs to be emphasized so that the couple can make up their minds whether this is relevant to their stage of life and reproductive health at a particular time. So just to run over the options and the timings, you can see this being represented diagrammatically. And the new thing that we have all learned in this thankfully and hopefully ending era of COVID is teleconsultations and other technologies. And we need to leverage this technology as service providers in terms of offering and taking part in teleconsultations, counseling, guidance, reference, and telelinkages. All of these can be done very, very safely and legally as far as termination of pregnancy is concerned. A number of resources like the Hamdo website, there are bots like Ask Tanu on social media and YouTube, infographics, helplines, and a number of excellent patient education platforms are available from all these organizations, the WHO, Ministry of Health, and RCOG, and they should be utilized. Couples need to be pointed to the right information on the internet, because the internet is a jungle. I mean, there's so much information out there that it's so easy to get lost over there, and credible information needs to be highlighted and they need to be pointed in the right direction so they get the right awareness. We know that teleconsultation has become a part and parcel of the COVID era, and it brings approachability and awareness very easily to the public. Of course, it lacks that face-to-face interaction, and demonstration can be a little difficult, but it's a great opportunity because privacy and comfort are ensured. There is cost saving because the number of visits are cut down. The only problem is that, once in a while, it may be that we miss a diagnosis in this kind of an interaction. So you can either provide the comprehensive abortion care services as hybrid, or use it to cut down the number of visits, etc. So I would like to end by just emphasizing the key messages, and the key message really is to realize the need for peri-abortion family planning care, bring couples on board to contraception, and try to see that each and every couple who comes to you for an abortion does accept some form of contraception. Capitalize on the basket and applicability in the peri-abortion period. Technology, Basav has spoken about beautifully, and we have lots that we can offer. And adolescent reproductive health also can be addressed in this online and offline model. So there's going to be post-test now, and I would request everyone to take part in it and give the feedback. So over to Ajay now, and he'll conclude the session, please.
Yeah, thank you so much, Parikshit. Once again, it's been a delight to have you here. And Achla, absolutely, you've managed and been throughout the session. Thank you so much for being part of this entire initiative that we are trying to drive across the country. And I'm delighted to share with the entire group here. Today was the 15th workshop of RAC. And kudos to each of these faculty members who have made it possible for us. And so far we have trained, and not trained actually, we have oriented 2,400 Foxians across the country through these workshops that we have carried out so far. In fact, it's interesting for you to see this now. there's another parallel session happening. So therefore, I've been in and out of it. And it's been absolutely motivating to carry out all of this and work with each one of you. So have you got the post-test?
No, sir, we have not got. Is it on the, where it is?
Has it been posted here? Not yet. Okay.
Not yet, sir.
Okay. So there's the post-test for you link. Each one of you can click it and save it somewhere, because we'll be closing the meeting. And my humble request is to all presidents and secretaries once again who are in the call and who are not in the call.
No, link is not visible. It's gone up.
Sorry?
Link is not
visible.
Scroll on the chat box, no, it will become visible. Just
okay.
Yeah. So my humble request is please ensure that the presidents and secretaries do take up this program in your society. And if they don't do it, you can also proactively do it in your society and precipitate the matter. And as I mentioned earlier, we would be sending across the ordinarium to all of you all, to the societies, and making sure that the societies thereafter take up this issue and further propagate this information and disseminate this across all the members. With that, thank you very much, each one of you, all the faculties, for being gracious and participating. And,
good evening, sir. Sorry, sir, to disturb. Please, we have not received the link for post-test.
Okay, the link is there in the chat box.
And if you, I think you put it again because it has gone up. So many messages coming.
Okay, I'll put it up again and again. But please remember, 3 times I put it. Do not click on all of them and submit 3 times.
So where to find?
Box.
Yes.
The link is there in the chat box.
Some post test and feedback.
I think, Santosh, we are closed for the day. I was in the other chat. Thank you very much, each one of you, every faculty member.
Yeah.
Sign in to Google to save your progress. Required. इसका क्या मतलब है? Sign in. Allow the chat opening pop-up window. पता नहीं क्या होगी वो. Allow करूँगा नहीं?
Yeah, I hope you're able to get the link now.
Yes, sir. Yes, sir. Thank you.
Yes, sir.
अभी आपको लिंक मिलता नहीं तो आप कंप्लेन करते हो, लिंक मिल जाता तो आप बोलते नहीं मिल गया.
मिल गया सर. अभी कोशिश कर रहे हैं सर, कोशिश कर रहे हैं. So nice of you.
Chalo, that's good. So
thank you, sir.
Yeah, so if everybody is done, even if you have not done, once you leave the meeting, you'll be able to do it. So do not worry. And we'll send you a mail also. Thank you very much, each one of you, once again, and have a lovely evening and all the very best. I'll see you all soon. Bye, Ashla. I'll see you soon.
शुक्रिया.
टेंशन मत लो, आपको भेज देंगे हम, ईमेल भी भेज देंगे, टेंशन मत लीजिए.
Thank you, sir. Thank you, sir. Thank you, sir. Yeah.
Thank you, sir.
Sign in. ब्राउजर ये देखो, इसमें फीडबैक भरनी है. कैसे भरूं? पोस्ट टेस्ट एंड फीडबैक.
Sir, submitted.
वो पीछे, इसके पीछे चल रहा, वो देखो, वो चाहिए मेरे को ये.
देरी मत करना, जल्दी आना।
हेलो हेलो हेलो
Yes. Hello.
hello ma'am, can I get the post test this link, because my phone got switched off. I could not give the post test.
Just scroll up in chats. It's there.
49,102 for area around 1,600 सुनो 1609 people.
Doctors, please copy that link and you can fill and submit the test, doctor. I'm going to close the meeting.
Sir, can we leave? We have submitted.
Just click on the link. Yes,
Yes,
that's what I mean. Then you can leave.
Okay, sir. Thank you. We have come.
Welcome, ma'am.
हेलो हेलो
Yes, sir.
सर मेरा इंटरनेट कनेक्शन गया था फॉर अ मोमेंट, तो फॉर्म नहीं दिखा मेरे को, तो हाउ कैन आई सबमिट द फॉर्म फीडबैक?
Sir, I'll send it, sir. I'll send it to your mail.
Sorry?
Okay. I'll send you a mail, sir.
Yeah, sir.
I'll send you a mail in some time. You'll get a mail to your link to your mail ID. You can
Yes, sir.
fill and you can submit through mail also, sir.
Hello.
Mail. Hello.
Yeah. How can
Hello,
we
sir.
get the certificate?
Madam, certificates will take time, madam, because now the section
No.
was ended, right?
No.
So we have to take a data from
We'll be
the
getting on
bracket.
mail or?
Hello.
Yes, ma'am.
Hello, sir.
Once
Hello,
the certificate
sir.
will be prepared, you'll get it through mail only.
No,
Thank
right,
you.
right
Thank
now or after 1 or 2 hours I can submit the feedback form.
Yes, sir. You can, sir. You just copy that link, sir. If you are there, you just copy the link, or else
Yes,
if
sir.
any of your friend had had the link, you can take from link the same link, sir. You just can fill and you can submit. You have to fill your details, your name and everything.
Okay, sir.
And you can do it, sir.
Okay, sir. You will send on my mail ID.
Yes, sir. It takes a
Okay.
time because I have to take a data from a system. So after that, I'll check who are submitted
No,
who are not.
right now, I have arranged. Where is the form so that I can submit?
Already it's there in chat box only, sir. Around at
Sorry.
549. 549. Madam Sudharani has posted the link. It's there in the chat
549.
box only. Chat box only. 549.
Chat box only. Shall I see and right now submit the form?
Yes, sir. You can do it, sir. You just click on the link, sir. You'll
In the chat box, na? In the chat
yes,
box.
Sir. Yes, sir. In the chat box.
At what time?
5:49 p.m.
5:49 p.m. na? Okay, sir. If there is query, I will call you.
Okay, sir.
Okay, sir.
The doctors, can I close the meeting?
Hello, hello.
Yes, sir.
Chat box, sir. Where is the chat box? I can't find here on the screen. There is a chat.
At the down, sir.
Hello.
Yes, sir. You can see in the bottom of your screen, sir.
In the bottom on the left side, there is a more. And in that, there is a chat. Chat is written. Chat
yes,
one.
Sir, chat. Click on the chat box, sir. Open the chat box.
Only chat. Chat is written. Niche meeting and minimize setting. Aisa. Chat.
Okay, sir. Then I'll send you a link, sir. I'll take a data from backend and I'll I'll send it, sir.
Link docsgoogle.com. This one is a link.
What, sir?
Whole chat box is not getting opened.
Sir, docs.google.com forms. There is one link, right,
Sorry?
sir? In the chat box, there is one link, right?
Kajal Mangu Kia to everyone. There is a link. Sorry? Hello?
Sir, if you can't find, then I told you, right, sir, I'll send you the link through mail.
And HTTP docs.google.com/form/D. This one is the link.
That one, sir.
Shall I click on that link?
Yeah, you have to click on that link and you'll directly go to a post and submit form.
Yes,
form.
sir.
You just fill it and submit us.
Okay, sir. I will.
So I'm ending the meeting, sir.
No, just sir, I have to submit the
you
form.
Just click, sir. No, you can do it, sir. It's not. No need of being in the meeting, sir. You can directly do that.
Submit. Last option is submit or clear form. That yes, I have to fill and submit. Na? I will get the certificate.
After filling everything, at the bottom you'll have a submit button. You have to click on the submit button. Then your posts and feedback will be submitted to Zoom.
Yes. Then I will get the certificate, na?
Yes, so later you'll get a certificate. So it takes a time, but surely you'll get a certificate to your mail ID.
For the on mail ID, na? Okay, yes, sir. Respectful
the mail ID
abortion
which you are registered with.
Here it is written respectful abortion care post test feedback form. Please ensure your mail ID and phone number. I have to fill all the details again, na?
Yes, sir. Write a proper mail ID, sir, so that we'll send a
only mail ID,
to your mail ID. Everything has to be, but the mail ID should be a proper.
Mandatory. Mandatory.
Because we'll
Okay,
send
sir.
the same certificate to the same mail ID. So the reason.
Okay, sir. I will submit. Okay, thank you.
Okay, sir. The doctors are ending the meeting.
Okay, sir. Okay.
Okay.